personal. So radiographic imaging of the hand and wrist. So this is a couple of talks sort of fudged together that show us roughly a scheme that you can use to look at X-rays. We're just going to go through X-rays at this. The original course is a 3-day BAHT Level 2 course that we run, and every year it's good fun. About 40 people come along. It tends to be, because it's BAHT Level 2, we get a lot of hand therapists, but we get radiographers, we get some ED doctors, we get nurse practitioners, we get anyone that's involved in hand injuries, really. And we just thought, given what's going on, lots of us are outside our comfort zones with day-to-day practice. It's nice just to get together as a group as well and run through things. We will run through bits and pieces. This is a 3-day course normally, and I'm going to put out another one in a couple of weeks' time when I know what our rota is, because ours is changing week on week, looking at wrist and some arthritic stuff as well. So we'll go through that in a couple of weeks' time, and we'll send that link out in the usual way. So we have any questions are fine. So I did it's really weird having an audience that's not talking while making noise, but there you go. I do a little bit of theatricals in the spare time I have, and I bizarrely did a fighting course before lockdown, obviously. And the guy that ran it is Rad, and very Rad-alike and very good. And he gave me this quote, which I think is a very nice way. It's not, you think, should I ask that, should I say? So there are no stupid questions. Every question asked increases the collective intelligence of the group. And the only stupid question is the one you didn't ask, which then stays in your brain and wakes you up in the dead of night. And that's so d'Orléans. And I thought it was a very nice way of putting it, because sometimes I think, should I? But actually that was a nice way of putting it, I thought. So, things I am not, the main thing is I'm not a radiographer, and radiographers, it's a 3-year BSc course, and they know an awful lot more about this. Remember, there are very many branches within radiography as well, and I'm definitely not a radiologist. So, what the report says and what I say sometimes differ, and that's always good to have that discussion with your colleagues. But what we do have the advantage of, compared to the radiography colleagues and radiology colleagues, is that we have the luxury of taking the full history, not just a squiggle of information, as little as possible, just to get things done quickly. So I have the luxury of having a history, the patient in front of me, and picking up those nuances that you might not get on a piece of paper from the referral form that you're sending to somebody else. And you get to examine them as well, so you can literally pinpoint where they're tender and correlate that to the history. And then sometimes, not always, I'm not a total scalpel jockey, we do have the advantage of then going in and finding out what was actually going on in its entirety by actually looking at the anatomy and the pathology within it. So much as the radiographers know a lot about images, and the radiologists know about the reporting and a lot about the science behind that, we have it as a tool in our kit, knowing that 95% of the diagnosis is going to come from your history anyway. So it's to be used in conjunction with these bits that we have. And a lot of it's our fault for putting crap on the request forms. So if you put query fracture, you see this a lot, maybe primary care referrals, query fracture because the patient falls and they've got pain. They come back and go, report says no fracture. Well, that's fine, because that's a question you asked, but it doesn't show the shocking basal thumb osteoarthritis that they had, which is the reason for their ongoing pain, even though there wasn't a fracture. But you ask a specific question, sometimes you just get that question answered. Most people would put something about that, I think, but not always. And I think there's something to bear in mind. Tim Davis's paper showed that post-distal radius fracture symptomatic basal thumb was quite prevalent, but that's another thing for another time. So, if you put poor information in, you'll get poor information out, and that's the cleaned up version of what I normally say on that. But yeah, something in, something out. So it's all about having quality, and spend some time with the radiographers in your unit. They will know a lot of much more smart ways of looking at things. So do go around and ask them specifically for things. So if you say, I'm querying a metacarpal head fracture, they may say, well, actually give you a quick call, pop around and see you, depending how close you are, and say, well, actually, do you want a Bruton's view, which would be a really nice way of delineating that anatomy. And, you'll be able to focus more on the area of concern, rather than asking for hand X-ray and get it and putting query fracture. Then you'll get a generic and they won't know exactly what it is that you're wanting. So yeah, if you ask for a hand X-ray and it's a distal phalanx fracture, they will try and change it to something more appropriate. So if you give them as much information as possible, you get a bespoke service. And I know most of the radiographers in our unit, so we can go around and have a colleague-to-colleague discussion. That's really useful because then we all learn from each other. So the other thing to ask is making sure that when you're requesting x-rays or looking at x-rays, you've got to think about how adequate and accurate and things like that, which we'll get to. But there's a well-known adage in orthopedics, which is my background before I sort of just went into hands, of one view is one view too few, because you can take one image, but if you take one image, you might get the wrong impression of what's actually going on. So this would be the lateral, for example, but then when you get the DP, you see it's not actually giving you the message that you thought you were getting. So I think it's worthwhile remembering one view is one view too few. Okay, so that's just one take-home thing if you don't remember much. This next thing is from the big talk, so it doesn't necessarily work as well on this screen, but what you're going to do is going to do a little quick task. And this is to replicate a busy clinic where you're looking at an x-ray and you're looking for your pathology. So what I want you to do, there's going to be a picture coming up next, and I want you to look at the picture and tell me, you can put it into chat if you wish, but you want to put in, count how many pens, okay? So it's going to be only a few seconds, it's going to be really quick, but you need to count how many pens are in this image, okay? You ready? Go. That's it. That's all the time you get. So if anybody's keen, you can put it in the chat. You might not be wanting to do that, to be fair. But have a little think about that. Have we got any responses yet? No, everyone's being quiet, that's all right. So I'll give you a chance in the cool light of day. What did everyone put? Sorry, put it on this side, it's no saying. So I've had varying results: 9, 8, 11, 9, 10, 10, 10, 9, 8, 10, 10, 10, 11, 11, 10, 9, 8. Yeah, I'll stop that now. But yes, a hugely variable number. Now, this is the thing. You're going in with one specific task, which is looking for the pathology, in this case, the pens. When actually, if you spend a bit of time on this, you see in the middle, all the information's there. But because you go in specifically looking for one task, i.e. fracture, pathology, I'm going in to do this thing, you don't take into account everything else that's going on. So actually, it's going to tell you here there are 11 pens in there. Remember, when you find one pathology, there may be another pathology, and there may be natural variants, which you need to exclude from a pathological situation, or sometimes variants that can be subsequently pathological, which we'll talk a little bit about at a different time. So, the thing to compare us, and we're certainly not comparing us with radiologists, but we're certainly looking at conditions in which we look at things. Now, we have these fixed screen things which have a slight angle on them, because the idea is that you look down at them. But we don't do our clinics stood up as much, we do them sat down. So a lot of variables occur. So this is normally how a radiologist or reporting radiographer would have their setup. So nice, expensive, comfy chair, all ergonomically sorted out, massive screen, subdued lighting. And this is something that we've got to bear in mind. We'll often have quite small screens. I literally just swapped mine to slightly bigger ones in my office so that I could look at this sort of thing a bit more appropriately. The resolution of the screen, when digital stuff came in, there used to be little stickers on the screens at quite a few trusts that said these aren't of sufficient resolution for diagnostic images, but they were running entire clinics off it. So be aware if that's still going on where you work. And as we all get older, eyesight becomes a variable, whether you're going to Barnard Castle or not. And then think of the ambient light as well. So if you've got light around you reflecting off screens, that can really alter how you can do things. And take it from the experts, the radiologists here, they will be looking at the optimal conditions. And that's really useful to bear in mind. So get yourself comfortable, sit down, take some time to consider it like you would for any other things, particularly if you're getting if you're getting into it and you're fairly early on in how you do things. So all we're trying to do here, we're not going to teach anyone to be a radiologist in an hour and a half or something like that, or a radiographer, but what we're looking for is a systematic approach. And the reason that we're doing that is just so you don't miss anything out, okay? So if you have gone through this, admittedly I forced that with the time for the pen situation, but everyone wants to go in and find something sexy. Everyone wants to go in and find some pathology and go, that's the one, oh, that looks bad, oh, that looks great. But we don't want to miss anything else, okay? And it still happens really commonly. Example, something quoted quite frequently, 40% of perilunates are missed on their first presentation. 40%. That's a huge miss rate for what's a pretty catastrophic injury. So it's certainly worth bearing in mind that you've got to go through this. And if you go through a system, you may get to the end of the system and find nothing, and that's entirely fine. And maybe the modality is not right, or maybe nothing to find. But the thing is, if you go through your system, then you know you've covered all of those areas. Okay, so the one that we teach and is quite commonly used is the ABCS format. Sometimes it's 2 A's, sometimes it's 3 A's. But the idea is adequacy. Is it the right image? As in, if you want a hand, you've got a hand, not a wrist, not a finger. If you want a finger, you've not got them all overlapped. So there's an adequate image. We'll talk about some of the things in a bit. Accuracy, is it the right person, is it the right side, is it the right date? Alignment, that's just a gross overall inspection of is it roughly aligned and does it look anatomically complete and whether it's in the right place. Bones, we'll go through how you go through the bones, particular parts of them, and it looks a bit slow, but you can really pick up some subtle changes there, which is really useful. Cartilage, which would include the joints, and then soft tissue at the end, which can add a lot, and that includes artifacts, markers for skin and stuff like that. So we'll take those all one by one. It's pretty straightforward. So adequacy is basically analogous to image quality. So if you've got an image, is it clear, is it blurry? And you will see, and I apologize later on, there's one that I use for demonstration that's got a bit pixelated as it's been blown up. So remember with this, it can happen as well, and how things are sent across in your system. You're looking for definition. If you've got good definition of the anatomy, you can talk about exposure factors as well, which we'll talk about. Positioning can be very different, and it's useful to talk to your department as to how they position people. You can get sort of DP hands, which should be basically flat with the receiver, that are slightly supinated or slightly pronated, and that will show you different things. A pronated view will give you lovely shots of the ring and little metacarpals. A slightly supinated view will give you much better shots of the index and middle metacarpals. So you've got to realize the biases associated with positioning involved. And as well, there's the classic 90-90 wrist views as well, which are reasonable. Exposure factors. So you've got to think about, is the good definition between the air and the soft tissue and the soft tissue and the bone. Okay, so sometimes if it's under-penetrated, you'll find that there's not very good differential between the soft tissue and the bone. Over-penetrated, you'll get the bone quite washed out and then nothing really in the soft tissue and no real difference between the soft tissue and the air as well. So exposure factors can be variable. A lot of those are preset, but sometimes there'll be, a big lad like me is going to take a little bit more energy to get the x-rays through his hand. So it's just something to bear in mind. Extra views, if you asked for a DP hand and a lateral of a finger and you've got the wrong finger, or it's not marked correctly, or you're not entirely convinced that it will be the side that you wanted it to be, i.e. you ask for a middle and it looks a bit more like an index and you can't be sure and they've not annotated, then that obviously needs to be sorted out as well. And artifacts, the classic one is the ring still in situ that's covering a transverse proximal phalangeal fracture, and there's still those going about. I've still got one, certainly. When you're thinking about adequacy as well, there's this other part that you can subdivide it into, which is perm. And I know it just feels like letters and letters, but we'll go through it in quite a lot, so it should become relatively second nature. As part of adequacy, the projections that you've got. So so in your unit, so when we ask for a hand, we'll get a DP and an oblique. We wouldn't, in a standard setting, get a lateral hand for various reasons. Like I said, it's about talking to your department and knowing what you get. The exposure, which we discussed, the contrast between bone and soft tissue and air, so next to it. And the region of interest is included. So if you wanted to look at a scaphoid, but you ended up with a hand x-ray, well, that means that you've not actually centered the beam where you want it to be. So actually you want your beam centered in the area that you want the most detail in. And then markers, right and left and the other way around. And make sure that it makes sense. Because remember, all hand x-rays are DPs, so you get an x-ray like that. Next time you have a look, think what side the thumb is. So on a DP, the thumb will be the thumb will be on the left. And on a DP of the left hand, the thumb will be on the right. And I'm not doing it up here because I'm not sure which way around it projects on Zoom. Okay. So yeah, no projections, adequate. We've discussed those things. Good. So accuracy. Is it the correct person? So if you're going to look by name, there may be multiple people. is the correct sides particularly, the correct date, and do beware in electronic systems, depending on how they store things. A lot of places will have things archived off-site, so you have to pull them down. And if you click on the next one, or what you think is the next one on the work list, it may just give you the last one available. So do be careful on that, particularly on the electronic systems. Alignment, it seems relatively obvious, but it's just a little bit of a clue as to what's going on. As you can see from this, that's slightly malaligned, but it just allows you to get your eye in for things. And you're looking at a general overall shape of what you're looking at, be that a hand, be that a wrist, etc. And it also allows for some comment on adequacy. Side point for this, given that we're getting onto it, it depends on your local setup, and I would say go and have a chat with your radiographers when you can. Some units for a lateral of a wrist will try and superimpose the radius on the ulnar. If you superimpose the radius on the ulnar, that's fine, but if you then start having patients with DIUG instability, which we do see a few of, quite a few I suppose relatively, if you've got the ulnar is fixed at the electron, obviously. People talk about dorsal translation of the ulnar, but it's not, it's a volar subluxation of the radius. What you'll find is that if you've got that offset, people will just continue to supinate until they align. So often you'll get a really odd image because people have tried to do it the way that the department's always agreed to do them, which is fine in the vast majority of cases. What we do, and what Galula, I think, spoke about a little bit as well, is if you get the proximal half of the scaphoid to sit with the capitate above it, that normally means that you've got the carpus at least in reasonable rotation to get a true lateral there. So if you think the capitate should be sat on the dorsal half of the scaphoid, that will give you a good lateral, and then you don't have to worry about the DIUJ. Bones. So we've done adequacy, accuracy, alignment. So there's the first three of the A's. Then we're going to go through the bones. So we're going to go through cortex. So that's the outside edge. And then the trabecular pattern. So the trabeculae are it's sort of the honeycomb appearance on the inside. And remember, you may not have a cortical breach, but still have a trabecular injury, and vice versa. So that's why you treat them as two separate things. And then you can talk about the type of fracture. We'll spend some time with that later, and the extent and location of the fracture as well. But remember, this is encompassing all techniques. So if you are using it for a non-trauma situation, which we'll do a bit of next time, then it won't be about the fracture, but we'll talk about fractures a little bit later. So we're going to go adequacy, accuracy, alignment. Looks grossly okay. We're going to just do the bone part here. So we're going to go along. Can you all see my cursor? Can I get a nod if you can? Yeah, cool. So you can see here and go, okay, so nature normally has smooth lines. Yeah, so then you've got the sharp angle here, which isn't quite right. Then you come over here, so that's a cortical breach, go across here, and then again, cortical breach across there, and then going along the ulnar. You see, you have a natural tendency to go, oh, I'm going to sit, and yeah, good. But then, if you keep going along the ulnar, you can see there's a cortical breach there as well. So there's actually an ulnar styloid fracture here as well. And then you're going to come down along the other edge. And then you can see how the normal honeycomb appearance is here, and then it gets more dense here. So there's an increased density, and then distal to that, there's this area of lucency, and then there's the distal pattern is reasonable as well. And again, if you look at the the trabecular pattern here, that is altered, and you can see there's a fracture line running there, and that's reasonable to say. But if you're going to go through, say there's cortical breach on the radial on the side, it doesn't go into the joint, but which we'll talk about later. Okay. This is the lateral of the same person, and again, coming on the volar cortex, the radius, you can see there's a cortical breach, and then there's this bit, and then dorsally, there's cortical irregularity all over the place. You can see how, if we go back one, yeah, so you can see this is increased density, because that's basically a double density of bone, because you've got this comminution dorsally, yeah, so you're getting this overlap of bone. So this distance from here to here has been increased, which is why when you take the X-ray, the X-rays don't go through quite as much. You get that whiter appearance, the more dense appearance, because there's just more bone there. And that's what the trabecular pattern will show you. So you can say that there's lines and alteration of the trabecular pattern, and you can say there's areas of increased or decreased density. And then you can say and keep it with a fracture or otherwise. Good. And again, like I said, you don't always get a cortical breach, but you can see there's certainly an irregularity in the cortex here, coming down the side. Again, cortical irregularity here, and then again, trabecular pattern alteration here. in quite a wide margin. So much as you have got a cortical breach, there's certainly an irregularity there, and you've got an alteration of the trabecular pattern. And again, sometimes it's really subtle, but again, cortex, very slightly changed, very slightly changed. Yeah. And if you look, might not project well on Zoom, but I promise you it's there. Can you see there's an alteration of the trabeculae there and there? And if you just imagine that's like a carpet that's just rucked up, yeah, and you can see it's jaunting out, yeah, and jaunting in. And you know that's what happens. You know that these buckle up, buckle fractures. Good. Again, that's what you're seeing dorsally. And that's the proximal part, and that's the distal part. If I go back, yeah. So that's the trabecular pattern change you're seeing, and one there again. Quite subtle, and I'm not sure how well that projects for you, but it's certainly there. Good. This just looks like a ooh. And that's what everyone's gut will say. They'll just go, ooh, that, But from a bone point of view, which is the only part of the ABCS we're doing at the moment, you'll just do exactly that. You go around the cortex, you're on the volar side, volar side, and then there's a step in the cortex, okay? And then it continues here, and then it's not in continuity, and then there's a bit more here, distally, and then there's a dorsal breach as well, with perhaps a loose part, and then again, dorsally, the cortex doesn't look normal, and then you get to this area here, and again, you get back to this normal cortex, which we've all seen, which is normal diameter and smooth. And then, same here, and so there's loss of continuity cortex there, coming up, some cortex evident distally, breach on this side, and then coming down proximally around. And then again, the trabecular pattern, you can see that the trabecular pattern's fine, proximal half, big defect there. So you can see how it's not always in a trauma situation. And this was a thumb abscess. So there's a bizarre thumb abscess with osteomyelitis. And E. coli was the cause of that, because I remember how it smelled when I drained it. But yeah, so we'll talk about those another time as well. So cartilages. So you've got to think about the type of the joint, the relations. So are they in relation to each other? I used to work with a radiologist who said the joint is either in joint or not in joint. And it's either enlocated, which means in joint, or dislocated. He didn't believe in this subluxation thing. And he may have a point, because subluxation is allowing you to sit on the fence somewhere between being happy and not happy about the position of the joint. So it's either in joint or out of joint, which is a reasonable argument to make, but you can do it in either way. With the joint space, particularly in things like the Eaton and Littler classification, the first stage of the 4 stages is joint space increase, and that's due to effusion, a synovitis. So increasing joint space is something that can be useful, effusions in particular, but the joint space is normally lost in things with degenerative processes, which we'll do another time. And then if things are within the joint as well, so sometimes you get pathologies which can produce things that come into the joint and foreign bodies in joints and things like that. So here, this is a nice bony mallet. That's a descriptive term, but a bony mallet can be many, many different things. We can see that the volar part of the base of the distal phalanx, is entirely dislocated. And you've got this V sign from here to here. Have you all heard of the V sign today? We've got this bit and this bit. So that looks like a V versus a nice congruent 2 plates sat on top of each other. So you can see they stack nicely dorsally. So the dorsal part is fine with the extensor attached. The volar part, or the palmar part, has FDP on it and has pulled it out. So you get this lovely parallel view dorsally, where the joint is, half of the joint at least, is still intact, and the volar part, which is out. And if you go around the cortex, you get a cortical breach. I'll give you the marks as well. Good. So this again is a sign of the V. So we're going to just do bones and joint space here. So you can see here, we've got a cortical breach here. And again, this is quite flat. If you push this down, everyone assumes that it just subluxes dorsally. But actually, this is an articular fragment, which is quite impacted up. And it's punched up into that lovely metaphyseal bone there. So even when you push that down, there'll be a big hole which you'll need to graft. And again, you can see there's a step there. So you can see you've got a cortical breach, an increased density there, because that bone, that honeycomb bone, has collapsed in on itself. So you've got that increased density signal. And again, your cortical breach here. But we'll talk specifically about fractures. The main thing here that we're talking about is there is a non-congruent joint. So you've got a fracture dislocation of the PIPJ. And this is enlarged just so you can see it. Okay, and this is just to prove that joint spaces can increase. Steroid injection under X-ray, same person, keeps increasing. Yeah, so that joint space increase, decrease can be relevant. It's not something you see a lot, but it's there. Good, soft tissue. So you can look for soft tissue swelling. Sometimes you can see a wrist with a massive soft tissue envelope around it. And that can be traumatic, it can be how somebody's built. But equally soft tissue defects, you can often see literally in the soft tissue shadows, little bits missing. An artifact suggestive of wounds, so you can see when dressings are on, you can particularly see things like iodine dressings, they tend to show it quite well. You can also look at periosteal reactions. Now you could put that in bone, that's entirely fine, but equally it could come into soft tissue, and it's not about one's right, one's wrong. It's putting it where you remember to at least think about it. It's not going to be there in many cases at all. Soft tissue calcification is also useful. Foreign body markers, in the old days it used to be paper clips, but I think somebody got scratched once, so now they use ballpoint pens, which can roll about a bit, so it's more of a thing. This is an interesting case, very nice lady, classic history. She'd been knocking around with this horrible pain in the fingertip for about 10 years, which we never got to, but which some people can get to the bottom of. And can you see this is the middle phalanx, middle finger, distal phalanx. So going around the bone, yeah, cortex looks fine, trabecular pattern looks fine. You go around this bone, it's not looking very similar to the middle finger. And you can see how you've got this scooped out appearance here. Can you see how the cortex here is a bit thicker to the opposite side? And if you look very carefully, you can see how you've got this round thing there. Don't know if you can see it well or not. Just try and draw that a little bit. Yeah. So you can just see there's a little dark circle there. Yeah. So there's a dark circle there. And what that was a glomus tumor. And the bone was reacting to it, but you can see there is this dark little shadow there. And it's sometimes, the soft tissue may not show it brilliantly, but I think you could see that. And it was that size and it was in that place. But the bone reacted to it. So the soft tissue can have an effect on the bone. Remember, bone is a living thing that turns over, so it can change in relation to things like that. Okay. Okay, fine. And this is one where every joint's out. Yeah, so you can see you've got a lovely visible base of the little metacarpal there, base of the ring metacarpal there. Can't see the CMC, can't see the CMC. And this is a full house index middle ring little CMC dislocation. Good. So again, on the soft tissue element, you can see there's a little bit more thickness than you'd expect. And the good thing about hands is you've always got your own reference point. So if you feel yourself over the little metacarpal, there's not that much cover there. It's skin, a little bit of EDC, EDM, and that's it. And then you're down to bone. You can still see there's a bit of soft tissue swelling. This is one that doesn't project brilliantly, but this is a periosteal reaction to the fracture. This is a healing fracture. And I'm sure lots of you have seen this where they've broken it 8 weeks ago. The wall upset them again, so they gave it another whack, and they come back with a refracture, not fractured, refracture, not fractured. And you see them not infrequently. Okay, so we're going to have a little look at the bones and the soft tissues on this one as well. So we're going to go accuracy, adequacy, alignment. I promise you it's the person I want you to look at. I promise you it's the side that he's bothered about. Alignment, we can see on the lateral view, it's not a brilliant alignment. You can see there's an obvious problem here. Bone-wise, he's maybe got an old injury here with a cortical breach. Cortex looks okay, but then it gets a little, see, it's nicely defined here on the ulnar side, and it starts to disappear off a little bit, and then it's really not a standard, what you'd expect. Very indistinct distally, not as broad as you'd expect over on the radial side, and then coming back again, maybe something going on there. You know, if you want to comment about the periosteal reaction, you can say, well, maybe something going on there, and then coming back down to where we started. Trabecular pattern. Going here again, starts to get a little bit more coarse distally, maybe a way of describing it. As well, you could argue maybe it's a little bit osteopenic here. The other thing to say with regards to how much bone is there for the base of the distal phalanx is that that is quite wide, but equally that's because that is probably a bit further away from the plate. Yeah, so you get a cast, very simplistic terms, like I said, not a radiologist or a radiographer, but you get a little bit more of a shadow cast onto that, onto the plate where the image is going to be received. So that's why it looks a little bit broader. But equally, then on the lateral, we can come here on the bones. We've certainly not got end-located joint. Again, the cortical breach, which would have lost much alteration of the trabecular pattern, articular surface of the distal phalanx of the thumb, dorsal, and again, cortex okay, but this bit again, the cortex does not look particularly normal. Going around the soft tissues, chunky thumb, very slender chap this was. You can see there's a soft tissue defect here, and here, and here. And you can see that thin line all the way down is the dressing. So again, lots of information that we're coming from. This was an open IPJ dislocation, which had been out for about 3 months. So what we had was a desiccated FPL here. You can literally see the ring of granulation tissue coming in from the edge, trying to heal it over, but it just couldn't quite get over that desiccated tendon. So we cut it out, popped it back in joint, put some wires, and it fused within about 4 weeks. Okay. This is just a comment on accuracy and adequacy. DP and slight oblique, but again, I would say it's not a hand X-ray because we haven't got most of the hand, and it's not a finger X-ray. You can see how we've got this slightly convergent picture. The natural hand will flop into that position. This is enforced. So you can see how this has got a bandage or dressings around it. So there's probably going to be an open injury. This much we can tell. Again, so the alignment is altered. That's why I mentioned it at this stage. As well, you can just see this, there's a lot of overlap here. And here, you can see it almost looks like they've got a droop, almost like a mallet on the alignment to the index finger. Okay, so this is the issue. And then we had a lateral as well because it was requested. But again, all wrapped up. So we've got some artifact over the top of it and not a huge ability to be able to tell. However, what they do have is a middle phalanx oblique fracture here. And if I go back one, it's actually, you can see there's an alteration of the trabecular pattern to the index there. And that's because you've got this oblique fracture sliding down and you've got increased density of the bone there. And that's relatively shortening the bone, therefore lengthening the tendons, and that's why we've got that mallet deformity. The other smart aleck thing is, can you see you've got this thin alteration to the trabecular pattern there? Yeah. And he also had an open wound there. It's really hard to see on the laterals, but he had 2 fractures there. Okay, so that's your AAA BCS system of looking at X-rays, and that will work for anywhere in the body, basically. So if you do anything other than hands, it would work as a system to cover all and make sure that you're not missing anything. It's just a nice little schema. And, you know, particularly when you're starting out, if you just write them all down and just write as much as you can in each section, that's a good practice to get into. So what we're going to do now, however, is talk about fractures, really. It's common injuries, but some fractures, basically broad terms. We've gone through this, which is the ABC, so adequacy, accuracy, and alignment, bones, cartilage, and soft tissues. So that's a way of going through things. Now, what we're going to do is focus now more on the bones and a little bit of the cartilage and soft tissues, and break down the fracture itself. So with the fracture itself, you can break it down further. So this will be the site. So where is the break? The configuration, how many bits, intra-articular, comminuted, oblique, transverse, spiral, all those descriptive elements. And that's going to tell me how it's behaved, basically, and how it will behave dependent on what treatment we're going to undertake with it. The displacement part is how badly displaced, angulated, rotated, shortened, all those bits as well. That will tell us a little bit about the soft tissue envelope, a little bit about stability as well, because you've got minimal displacement in a stable configuration, that's going to be a stable fracture. All these things are good for describing the injuries, but as well, it's good for being able to help you make decisions on how you're going to manage them. And if you find yourself going through the system, you'll go, okay, so it's not comminuted, it's transverse, and there's minimum displacement. Well, that's probably going to be a relatively stable fracture. Therefore, we can treat this, relatively minimally with immobilization to get function back as much as possible. So by the end of this, I want you to be able to say, this is a DP, an oblique radiograph of the right hand, grossly aligned. Let's say it was an adequate image. Fracture-wise, just for this part, we're going to narrow it down. So there's a fracture in the middle metacarpal. It is multifragmentary. It is a combination of spiral and oblique. There is shortening and radial translation of the distal fragment. The fracture is extra-articular and runs in the middle 2/3 of the bone. Sounds schmancy, it's not. It's just running through the site configuration displacement. Then remember the 11 pens, and then say there is also a fracture running through the index metacarpal head. There is alteration in the trabecular pattern. It is intra-articular. There's a cortical breach. Is minimally displaced. Yeah, so keep on looking. That's just a quick version of that. Okay, that's to wake you up. Apologies if you spill your wine. This is Ribena about it, not wine. So I still get phone calls from people asking me about very boring things. The number of people that think a foot is similar to a hand still depresses me. Still people, but it's really similar, isn't it? Like, it's really not. It's really not. Equally, hips I left behind a long time ago. You really don't want my opinion on the hips. However, if you phone me about a hand, I will talk to you for hours. Still really is the best thing, really, isn't it? That's why we're all here. But yeah, you've got to convince me nowadays. Most people, not everyone, but most people have a right and left, and hand dominance and the injury side is sometimes relevant. But a lot of people do a lot of things bimanually, so it's not a be all and end all for it, but some things you'd work a little bit harder, particularly for replants for dominant hands and things like that. But then you've got to narrow it down further. Now, I know you will all know the anatomy for this, and thanks to Netta for borrowing that. You know, you can talk about things, but then it's different for each bone, and we won't go through the carpal bones in particular. So if we're thinking about the long bones, so the metacarpals and the phalanges, you can break it down much more easily. So you can either go with the true anatomic terms, which are going to be your head, your neck, your shaft, and your base, but you'll get some nerd like me that's going, well, actually the base is a square based on the diameter of the bone at the widest part. And, you know, and then people say, well, it's not a neck, it's easier if you do this one in yellow. So if you break long bones into thirds, and this works for tibia and femur and foot boring stuff, if you break it into thirds, there'll be a distal, a middle, and a proximal third. And equally, you can then break it down further into the junction between the distal and the middle and the proximal. So you can have the proximal third, the junction between the proximal and the middle third, the junction between the middle and the distal third, and the distal third. So that automatically breaks it down into 5 discrete regions, and it can span across those as well. So it's a nice way of breaking it down without people going, oh, well, is it metaphyseal or epiphyseal? If you're talking thirds, everyone knows what we're talking about. There's no nerd points. So fracture patterns. What would, and it's hard without the noise, so you can put it in the chat if you so wish, how do people describe this? So there's a fracture of the ring, metacarpal. Would you say, how do you describe that fracture? 2 parts, it's extra-articular. We're not talking about displacement. We're literally just talking about the fracture itself. You've got me interested. So right ring finger, metacarpal, midshaft. Would anybody describe it in any way? No, nobody's going to type. Transverse, very nice. Thank you, Fiona. So yeah, transverse. We normally get a little bit of argy-bargy at this point, and this is why I put it in. Fractures up to about 30 degrees will be described as transverse, because up to 30 degrees, they'll kind of behave almost like transverse. It would be very rare to get a purely, absolutely bang-on transverse fracture, at which point they're all going to be oblique. So up to 30 degrees, it would still count as a transverse fracture. Okay. So you've already got that one. Thank you very much. So transverse, oblique, and spiral. So there are options. We'll go through these together. This is borrowed from AO, who've got a very nice website if you ever want to look at general fractures. They've got subsections for the hand and wrist as well. So basically, all fractures will be configured of 1, 2, or more with combinations of a transverse fracture, again, up to 30 degrees. It will behave like a transverse fracture. An oblique fracture, which is literally just a diagonal line, and a spiral fracture. And I would say that's like, you know, when you uncurl a loo roll, and it opens up a little bit. And equally, it will be done by a rotational force as well. And it will behave with a rotational element, which is why they can be slightly challenging. So basically, all fractures will be divided into transverse, oblique, or spiral, or a combination of 2 or more. Okay, and even those really, really mushed up injuries that you see are still just a very complex combination of these, which is very hard to describe. And this is why it's worthwhile breaking them down, because it's pointless describing them unless it's going to make a difference, okay? And it will make a difference because transverse fractures, if you're stacking the fragment fractures on top, particularly a two-parter. If they are transverse or pretty close to transverse, up to that 30-degree margin that you're allowed, they will behave relatively stably. Yeah, so we'll go up to 30 degrees. Okay, that's somebody else allowing me to do that. Okay. Then there's an oblique fracture, which is beyond that. And again, if gravity is acting upon it, it will slide down that slide. Okay, not my child. That's from a catalogue or something. So basically, with the same forces across them, which will be your extensors, your flexors, people loading them, it will slide down. If it's got transverse and you're going to sit on those boxes, it's going to be pretty solid. If you're going to sit on a slide, you know, even at my size, you'll probably still slide down it. Might be a bit squeaky, but you'll still slide down it. And the difference between the oblique and the spiral is that the spiral is the helter-skelter. So along with the going down the fracture obliquity, you will get rotation as it shortens. Yeah. So as it shortens, it will get worse. Okay. So, sorry, whoever did that, apologies. It won't go, you see. So this is the transverse fracture. Okay, that's pretty good. We've gone through that. How do you describe this fracture? Good excuse for me to have a drink. Yes, oblique. Very good. Oblique, 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 oblique. Very good. There's a reason, and there's an order, isn't there? That's the way I'm going to load it. Great. So this is an oblique fracture. And you can see how that might just want to try and shorten with time. Equally, what's this one potentially going to be? Yeah, so we've got spiral. Thank you very much for those that have sent me that. And the other clue for this, if you weren't entirely sure, is you're getting a pretty good oblique / lateral of that metacarpal head, aren't you? Compared to this one and this one, which is pretty end on. So you're seeing a lot of that across there, yeah? So that's a spiral fracture, and you can see how you've got a single cortex thickness. So the trabecular pattern here, you see how it's slightly more faint here, and that's got that loo roll unwrapping thing that we had on the pictures before. Great, so that's spiral. Oh, now this is a tricky one. It's not, because it can't be more than one of three things, and even my memory can still make me remember three things. So we've got the oblique part here. You could argue it's two parts oblique, because actually the gradient of that changes. But then you can see how you've got this alteration of trabecular pattern. The density changes because you've got a double thickness of bone here, but you've only got the single thickness from here to here, and it's got that characteristic peak to it as well as it unwraps. Yeah, so you've got an oblique, and then you've got the spiral part to it. So automatically you've said a left middle finger, proximal phalanx. It's in more than two parts, so beyond two, I just say multifragmentary. So it's multifragmentary, which is a combination of oblique and spiral parts. So everybody knew that already, but it's just putting them in that order. It makes you sound like you know what you're on about. Made a career of it, don't worry. So you've got this combination of them. We'll talk about displacement later. The other thing to bear in mind here is that it does go very much into the joints. The joint capsule sort of comes along here, so it goes into the joint. Now, whether it's into the joint surface, you can argue about, but it's certainly worth bearing in mind. Okay, there are cases where things are a little bit more obvious. You can see here, you've got this obvious break into the trapezium. So we're going to go through it. There's a cortical breach. Yeah, breach there. Alteration of the trabecular pattern with lucency going almost all the way through. I can't see a way out, but it could well be on the way out, but just held together. And this is something that's worth bearing in mind. People often will talk about a 2 millimeter step being what's worth fixing. And really, there's not great evidence behind that, other than that most people can get it reduced within 2 millimeters. So it's when technical ability gets it to the point that it would probably be better with the risks associated to get that more aligned than it is at the present time. But the thing to remember is, for that trapezium, you can walk over cow grate, yeah, because it's flat. Having a gap is okay. It will still work as a smooth surface. You can drive over that. But if there's a step in that, it will cause crepitus, it will grind, and it will give early degenerative change in that joint. At least that's the way. Whether that's symptomatic or not is another argument. Okay, so here we've got, don't know whether it's left or right because there's not a marker, and you could maybe make a guess at it, but let's not guess. But we've got a fracture of the proximal phalanx of a thumb, Probably a combination of oblique, multifragmentary. Can't tell if there's a spiral, but I think it's probably multiple obliques. Looks like a crush injury, doesn't it? It's just gone like that. There's an intra-articular component, both distally and proximally. Alteration of the trabecular pattern, cortical breaches. Yeah, we know that. But actually, if you cover this bit up and cover that bit up, that will be fine. That will be fine if it fills in with scar cartilage, fiber cartilage. And actually, we splintered that, and he did really well. And he's probably about 5 years down the line now, doing really well. Opening that up is just misery. It's really not miserable. And then everything gets gummed together with, because you've got to use a big, broad, one of those ladder plates, and then everything sticks, and then it doesn't move. And you wouldn't know if you've got arthritis anyway, because it doesn't move so well. So yeah, that did really well, just conservatively. So fracture displacement. This is how long I've been doing the talk. It used to be a sat nav. It had to be updated not so long ago to get onto Google Maps, or other are available, Apple Maps, all the rest of it. So fracture displacement. This is just giving you directions to where the bits have gone, okay? And that will give us information about how the fracture's behaved, about the fracture energy, about the soft tissue envelope, and about some of the stability factors of the fracture as well. So you can only really move bits in different ways. So you can move things in translation, and that to me is off-ended, so how off-ended something is, and that's literally side to side. Shortening, so that can be off-ended and shortened, or impacted. Then you get angulation, which is pretty obvious. It should be somewhere, and it's pointing that direction or the other direction. And rotation. The thing to say about this is, remember Prince William at the beginning? Well, one view is one view too few. So you are just commenting on the 2D image that's prescribed, that's given to you. Okay, you're only describing what you can see on that image. So on the DP, you'll talk about translation, shortening, angulation, and rotation. And on the lateral or oblique, you will again talk about it, because the two together will tell you more. Okay, so on a DP, you'll know which way it's gone radial and ulnar, but you won't know whether it's gone palmar or dorsal until you look at the lateral. Okay, so when you're talking about translation, the two orthogonal images, because you're turning a 3D problem, the hand, into a 2D representation, which is your picture, which is why you need the two, and you need to put them all together. So we'll take a bone and break it. Theoretically, those bones can go, those bone parts can go in any direction possible, okay? And we do occasionally have people arriving in different vehicles to bits of them coming in other vehicles. So when you talk about, well, it could be anywhere, sometimes they are, so that's something to bear in mind. But you do have people arriving with not bits, and then other people having to find the bits and bring them with them sometimes, which isn't much fun for anyone. But that's why it's important to think about this displacement terms. But the vast majority of people will say the distal part, because it's much harder for people to move me than the distal phalanx. So the distal part could go left, the distal part could go right, and the proximal part could go left, and the proximal part could go right, but we talk about the distal part. Now, not many images, X-rays nowadays are actually calibrated, unless you ask for it specifically. So it's normally easiest when you talk about translation, so how off-ended something is, to talk about percentages. So I say this is 25% off-ended, translated, 50% translated, and 100% translated. So it's all easily doable as percentages, and then nobody can argue with you either. Then you can have shortening, and what we know has happened is it's just gone off in this direction. But it's hard to say that. And what's made it easier in some ways, but more difficult in others, because people don't look at X-rays, is people look at the reports and people look at digital images. When I was an SHA, we still had the huge packets. There's a gag that went around a long time ago that the only reason I got a job was because I'm big enough to hold multiple packets of X-rays under my arms. Hopefully not true. But the reality is that in the old days, you had to phone somebody and tell them what the X-ray looked like accurately, otherwise they wouldn't come and see the patient. Yeah, so we used to be, the person that was deciding whether somebody would be admitted without actually seeing any images at all, because there wasn't any way of showing them electronically because there was one copy. So you can't just say it's gone there or look at the X-rays. You've got to be able to describe it. So when we're describing it, we're saying, well, actually, it's gone in this direction. But then what's going to happen? You're going to get a goniometer and work out how many degrees and how far, and it gets a little bit impossible. So what you're actually going to do is break it down so it's translated 100% and shortened a relative length, or you can do it in millimeters if you want. But you're going to say there's a translational part, and a shortening. Rather than saying the bit's gone here, you're going to break it down into those vectors almost. So you've got translation, radial ulnar, palmar dorsal, and then shortening as a percentage of the length of the bone, or in millimeters, whichever you're going to be easier to describe. But remember as well that shortening doesn't necessarily just happen with translation. It can happen due to impaction. So sometimes if you get really significant force and comminution, it can be shortened with no translation. So that's why it's important to say whether there is or isn't first. Okay, I normally do it as a relative amount, just because then you don't get anyone upset. But that was a transverse fracture. We know those are relatively stable. So if it's a transverse fracture and that much translation and shortening, that's got to have a lot of soft tissue damage to allow the bone to move that much. So that would be a slightly different type of injury. With an oblique fracture, we know that it just wants to do that. Okay. So again, it's exactly the same problem. This is where my second showbiz story, I think, comes in. Not really. So like New York before lockdown, this is really taunting me now. It should be in America at the moment, actually. What I like to do, I like a good show. And then, I'm going to get the Grand Central Station. But I'm not Spider-Man, so I can't go to the top. So we're literally going to go on the lovely grid structure on West 47th and then down Madison Avenue. Yeah. So it's just that grid structure to something that's living, moving, breathing. And it's not as simplistic as this, but we're simplifying it to be able to use it in a common language with each other and help improve our treatment outcomes. So again, it's exactly the same as the previous. We've got some translation and we've got some shortening, and that's all that's happened. Okay, a way of talking about angulation is very easy. It should be here and it's now over here. Yeah, don't have to argue about that. This is obviously a child. There's cortical breach, alteration of the trabecular pattern, but we're just talking about angulation for this, okay? It could be that it's massively extended as well. It could be that it's massively flexed as well. These tend to be extension ones, don't they? We know that. But all we can say on this DP view is there is ulnar angulation of 40 degrees, okay? I'm sure you're all better than me and have your goniometers to hand, so you can tell me exactly what it is. But it is worthwhile getting it reasonable for any corrections that you're going to do. And again, what we're saying is the bone should be here, and now it's pointing here. So you can say there's dorsal angulation because we're still talking about the distal part. Yeah, dorsal angulation of something like 40, 45 degrees, okay? So it should be here, and it is there. Now, if we're going to go through the whole bone part of the fracture, okay, so you can say there's a fracture of the proximal phalanx. Can't really tell exactly which one it is, okay, but you'd be able to see it. This has been zoomed in a bit. So transverse, two-part, extra-articular. Okay, if we're going to talk about displacement, well, actually, there is some translation, okay? The distal part has gone palmar, yeah, because that's the dorsal cortex. And then the next time you see the dorsal cortex, it's there, which is more palmar. So there's palmar or volar translation, yeah. There's also probably some shortening as well, yeah, because this bit should be stuck up here. So we all know it's an extension injury and it's gone into extension because of the central slip pulling on it and the FDS counterbalancing it. But the reality is the bone has moved forwards and then angulated. So even though it looks like a pure angulation problem, there is still some volar translation and some shortening to it, yeah. Should be there though, and it is there, and that's the angulation part. So already, even though we've used this as an example of angulation, it is still got the other elements there to be thought of. Rotation is really hard to assess on X-ray unless it's like the one earlier. Remember the spiral little finger metacarpal shaft fracture, where you got basically a lateral of the metacarpal head and a DP of the CMC of the little finger. So what you do is you normally assess that clinically as well, okay? And we still get things like this, which is malunited in significant rotation, which is a big functional problem. I mean, lots of secondary stiffness there. You can see how the PIP extension creases have all disappeared. So that's really important to catch relatively early on. Okay, joint incongruities we'll run through a little bit. Sometimes you get frank dislocations like this. This is obviously a child. We've got a frank MP dislocation. Everyone's aware of this thing as well. I was talking to some colleagues the other day. So this is the new version of what's called a red dot. So in the old days, there used to be literally a sheet of red dots in the X-ray department. If there's an obvious fracture or pathology, they put literally a physical red dot on that. And then when we pull them out as the junior SHO and A&E, you go, and you knew you had to find it. And sometimes you had to go around and ask the radiographer where it was, but you still had to find it. So that's what red dot became, and then digitized, you couldn't really do it because it's all black and white. So this, or literally the words red dot are put on there if there's a pathology for you to see. Doesn't mean if there's not one that there's not a pathology, but it just means it's helping out a little bit. And again, we've got a bare metacarpal head here and a bare proximal phalanx. And that's pretty obvious because they're nowhere near each other. They're totally apart. And again here, you can argue, well, there's some bone touching, but the articular surface here and the articular surface in here are not even touching. So again, total dislocation. You can see, worryingly, that the DP, which is slightly rotated, to be honest, from an adequacy point of view, but this view, you could think, well, they've got a collateral ligament injury because that's opened up a little bit. Not at all. One view is one view too few. Remember that? So here you go, well, it's probably okay. Totally out. Totally out. So you've got to be careful on that. But yeah, it's about accepting and not accepting things. Again here, another wall hater. Punched here, you can see the cascade has gone as well. So you normally get a normal cascade of index, middle, and then dropping off down to the little. You've got a little bit of that, but again, suddenly drops off here. An overt, you've got this overlap, you've got an increased density here, which is actually hamate on top of metacarpal base. Yeah, and you can see it's slightly rotated as well because you've got a little bit more of that metacarpal head. And again, your helpful red dot if you can't work out where it is. And some soft tissue swelling, and that contours, you've got a double soft tissue contour there. So you're seeing this, and again, that's quite a lot of soft tissue over the base of the little metacarpal as well. Okay, this again, frank dislocation, proximal phalangeal head, middle phalangeal base, not even touching. The thing to say about volar PIPJ dislocations is they are always, 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 always a central slip injury. Okay, so the dislocation part of this is relatively straightforward to get back in. Yeah, give it a good pull, a little bit of overpressure to the base of the middle phalanx. This is always, always, always a central slip injury for a couple of reasons. One, the insertion's here, and number two, the excursion of the central slip at this level, at zone 3, is a fraction of, is 4 or 5 millimeters. It's really not very much, depending which study you read, but it's only 5 millimeters or so. And that will not stretch from supposed to be here all the way down to there. And it literally strips it off as it gets peeled off over that front of the proximal phalangeal head. So this is always a central slip injury. Okay. As an incidental, and something that we come up with quite a lot on the course is, see this bit, everyone's worried that it's an abnormality or a fracture. This is a sesamoid, and some people have lots and lots and lots of sesamoids, and some people don't. You can see here, this is the thumb coming in the bottom corner. He's got a sesamoid in his thumb, probably MP joint as well. But again, see it's well circumscribed. It's got a smooth edge, no cortical breach, normal trabecular pattern. That's just a sesamoid, just as an aside, because we get that quite a lot. Again, you can see you're going to go through all the things. We've got a DP and lateral, DP on the right here and oblique on the left. Can you see you've not got much metacarpal head sat under that little finger proximal phalanx? Again, an entirely bare proximal phalanx, base, articular surface. And you can see how this little metacarpal here is quite flexed. Yeah, because once it pops back, it pushes that little metacarpal out of the way. Remember that the little metacarpal is very mobile. Yeah, it comes forwards and backwards quite a lot. Okay. A clinical point to make about these is that they, you'll often get to the point where they're irreducible, because what happens is the long flexors wrap around the back, and the more you pull, it almost works like a noose, and it makes it tighter for the metacarpal head to pop back underneath that proximal phalanx. So often you've got to open these, which is what we did. And when you open them, the nerve is normally just sat there under the skin, so you've got to be really careful going through the skin. But then that's how it looks, so entirely bare, entirely stripped, excuse me. And then you hook the flexors out from around the side and over the front. Yeah, and these are the FTP and FDS being hooked over front, and that's the volar plate of the metacarpophalangeal joint still attached to the base of the proximal phalanx. Okay, so this is your frank dislocation, which I'm sure you're happy with now. What we've got here, again, is you've got this articular surface here, and you've probably got that bit there as well, and this part here. So you can see you've got this dorsal V, or this V sign. Yeah, they're not stacking up like plates. They've got a little bit of subluxation, so you'll get this non-parallel articular surfaces, yeah? So this is this dorsal V sign. Let me clear that so you can see that, yeah? So you've got this is the base of the middle phalanx. This is the head of the proximal phalanx, and you've got this dorsal V, and that's a sign of a subluxation or frank dislocation, depending on what you're going to go for, okay? So, another way of being able to look at these is you can draw these tangential lines off the back of the proximal phalanx, or in reverse, which we'll talk about in a second. And if you've got articular surface, which is this bit, not this part here, the actual articular surface, which is from here, which is dorsal to that line, then there's a subluxation, yeah, or an attempt at a dislocation, depending on your terminology. So if you've got articular surface dorsal to this line, you're going to have a subluxation going on, and that can be quite subtle sometimes. Or the V sign, which we've probably gone on about too much. And remember, these can be open, and it's a box of injuries. It's your volar or palmar plate, your collaterals, and your central slip at the back. And it's rare to do a pure DP dislocation. There's normally a partial collateral at least. Okay. Again, quite a subtle injury, but when we're looking at things, we've got an increased joint space, and they're certainly not congruent either. They're not sat on top of each other. We've got this opening up volarly. Yeah, so you've got this very broad space. So number one, you've got a big space, and you draw this line, and you've got articular surface of the proximal phalanx now being uncovered by that. Yeah, because if it was congruent, even if you flexed it, the tangential line would still not go through that most of the time. Just little tips and tricks. Again, probably done that a little bit too much. Very straightforward. We tend to use DP and oblique images for fifth metacarpal shaft fractures, partly because the angulation probably isn't that relevant. Paper I was involved with a while ago with Tim Davis, Frank Burke, Tony Westbrook, showed that malunion of necks and shafts really doesn't matter. I used to work for somebody that said, when I started working for him, I said, we've got a fifth metacarpal shaft fracture. It's really quite angulated. And he said, oh, that's fine. You can accept 10 degrees more. I said, oh, have you seen the x-rays? He's like, no, whatever number you give me, you can accept 10 degrees more, which was his way of thinking. Sometimes it's quite angulated, but he was happy with anything. Yeah, so these fractures, so if we're going to go in descriptive terms, there's going to be a alteration of the cortex, yeah, so the cortical breach. There's an alteration of the trabecular pattern. It's two parts, the subluxation. It's oblique, because it can't be transverse, it's oblique, and it's intra-articular, and it's got dislocation. So we can call that a Bennett's, but we know that Bennett's can be hugely variable. It can be a little fleck of bone, it can be most of the base of the surface, which is why calling something a Bennett's or a Colles is fine, but it doesn't tell you how it's going to behave. You can have minimally displaced Colles, or you can have off-ended stuff with massive amounts of comminution. So when you're calling something by name, great, but just be sure that it's going to transmit that information to your colleagues about what's actually going on. Okay, and the deforming forces here are the palmar oblique or beak ligament, which holds onto this part in the first web space. The web's not there, but you know what I mean. And then you get the APL pulling down here, causing the dislocation. But equally, that's Bennett's with most of the articular surface fine, and that's Bennett's with a frank dislocation of most of the articular surface. So, and it's Bennett's, slight variability there. And Rolando is where you've got more comminution and intra-articular in this sort of T shape almost. But again, it's an oblique and an oblique, and it's three parts, and it's intra-articular, and there's dislocation of one of the parts. Yeah, they normally get some shortening with that. And you just go through exactly the same system to describe these, rather than just labeling it Rolando or whatever you want to do it. This is just to talk about these little difficult fractures, these unicondylar fractures, either in the middle phalanx or the proximal phalanx. Because they are condyles, they are two. These are bicondylar heads, yeah, and they've got a nice groove in them. which means that it gives some stability, which is why you've got the V at the base. Yeah, you know that they sit in there. When you get one offset slightly, it doesn't look very impressive on the DP, but when you turn around to the lateral, you'll see a lot more of that one condyle sticking out. And this is what I want to say. It's like the soldier sticking his head out of the lineup. Yeah, so it's just that forward, and that will lead to rotation. Because if you think the axis is moving this way, if you then push one forward, that means that your axis of flexion is going to be offset there and give you some scissoring. So that's just a subtlety there to show you've got a lot more of that condyle than you'd hope for. Avulsion fractures, we'll all see in these volar plates, UCLs. The thing about avulsion fractures, it's fine to say, well, the bony part will heal back, but remember that the ligament or tendon will often undergo hysteresis, so they will stretch out too far, and then when they recoil, they don't recoil back to where they were. So often these will be a little bit lax afterwards, so just warn them about that. Again, bony mallets, that one's congruent. You can treat those in splint, and the amount of joint surface in joint is really what the bony mallets are all about. They tend to do pretty well. So this is a lovely chap, 27. He had an injury playing a sport. If I told you what it was, it gives away. But I asked very specifically for a DP and lateral of his ring finger. And alignment-wise, it looks okay. Alignment-wise, it looks okay. It's a left, which it was. It's got a red dot. Yeah. Adequacy, it's a little underexposed officially, because you can see how non-infection have got through, and the difference between the area and the soft tissue and the soft tissue and the bone isn't the best, but it tells me what I need to, so I'm not going to whinge, which is unusual for me, for those of you that work with me. So you can go through the cortices. Oh, hello, something going on there. Cortices again, something going on there. Cortices, well, there's no volar cortex until we get here. Getting dorsally, it's cortical breach dorsally there. Trabecular pattern looks okay. Oh, alteration trabecular pattern there. Looks okay. Trabecular pattern there. And cortex, could that be? Okay, come back to that. Cortical pattern there. Cartilages in joint, in joint, in joint. And you can do this. So B, B, C, C, S, S, whatever you want to do. Not massively swollen. Maybe a little bit of soft tissue calcification there. Or is it just a bit of this that's being left behind? And again, DP-wise, looks okay. Maybe some more swelling evident there. You know, that's a lot of swelling for that level of PIPJ. Again, cortices look okay. Can you see here? This is really subtle, so if you can zoom it yourself. Can you see here? There's an increased density in the trabecular pattern. And then you can cross-reference from here. To your lateral and go, it's increased density because there's too much bone at that level, which is also seen there. Can you see that? Just subtle there, yeah? Then coming back up, cortex, there is the cortical breach. Gave the game away. Cortical breach here, and alteration of the trabecular pattern there as well. Can you see? So you can see you've got this FTP avulsion, a bit of bone in the sheath, transverse fracture at the base of the distal phalanx as well, which you can see on all of this. And then it's whether you're brave enough to assume that the FTP is still attached to that, or whether that's a bit of bone left behind and the FTP is actually further down, which is a discussion point. So this is him on the table. Normal cascade, because FTP and FTS are working to his other 3 digits. FTS is still working, but you can see how much FTP does to tuck that down. So straight DIP, less flexed PIP compared to what it would have been had the FTP being attached and functioning. Opened it up, the bony fragment was there. It was stuck at that middle phalanx level, which, depending on what you read, is either the chiasma over the FDS or the A4. I think it's the A4 because it's the narrowest part of that fiber osseous tunnel. We brought it back. There was a nice footprint where it had come from, because fractures healed by hematoma, then soft callus, then hard callus. And we managed to just put that exactly back where it came back. I didn't do it over tight, I promise. That's because the FTP has been unopposed for a week and it was pulling down. So that came back pretty nicely. And the K wire is only there for that transverse fracture as well. Otherwise, it would have been wobbling that at the end. And he did pretty nicely. So we've done AABCS, adequacy, accuracy, alignment, bones, cartilage, and joints and soft tissues. That's a thing that will work anyway. If you're going to get down the bony injuries, particularly, then if you look at the site, whereabouts of the bone, and then the long bone, remember the distal third, middle third, proximal third, junction in the middle and the proximal, junction in the middle of the distal thirds, takes it down into 5 distinct regions. Configuration, how many parts is it? 2 parts or more. More is multifragmentary. Try and avoid comminuted, because comminuted and complex, meaning open, got confused for a little while. So we go 2 fragments or more. More than 2 is multifragmentary. Then it's intra-articular or extra-articular. And then is it transverse, oblique, spiral, or combination thereof. Displacement is going to be translation, shortening, angulation, and rotation. And if you put all that together, just going through it, checking through it, even if you have an A4 printout just to get through it, you shouldn't miss anything, and you shouldn't shoot yourself in the foot. The jokes have been dreadful, and I apologize. Okay, so